I try to be relatively impartial, but I will be first to admit this is my favorite talk in this series because the history of surgery is just, it's so amazing, so clever, and so grotesque. There's just so many things to talk about that it's just a lot of fun. So we will jump back for a real quick historical review before we go a little bit into the future. So let's remember Hippocrates. What did Hippocrates, the father of Western medicine, have to say about surgery? Really not a whole lot. Most of the treatments that he focused on were things that would adjust the bodily humors through diet, purging, bleeding, things like that. And in fact, one thing that's in the Hippocratic Oath to this day is an injunction against what's called cutting for the stone. Now, sometimes this is interpreted as Hippocrates saying that physicians shouldn't cut people at all, but what was going on in ancient Greece is there were actually people who were specialists in cutting stones out. Now, the stones that they're referring to are not kidney stones, they're worse. They're bladder stones. They're stones that have formed inside the bladder. They can be huge. There's one on the right side of the picture there. And these things are fatal. They will block the urethra, block the ureters, make it very difficult to void urine. And so there were people who specialized in taking them out. However, taking them out was not even remotely a pleasant process, because when I think about the bladder and anatomy, I think, oh, you could do a suprapubic approach, maybe go that way. No, it's a perineal approach. No anesthesia. They just went in, hooked it with a tool, pulled it out, and what's kind of hilarious is that people would ask the stonecutters to come, they would take the stones out, but everybody around them would pay them in advance, because then they would jump on their means of conveyance and get away as quick as they could, because everybody in the village would then try to, throw them out or beat them up because it was seen as something that was terrible to do, and yet they arranged for it to happen in the first place. So that aspect of surgery was considered a bit unreputable, and Hippocrates considered it to be poaching on someone else's domain to have his students actually working on that. Now we come forward to Galen, and last time when we talked about treatments, Galen, the big medical authority for 1,500 years, really hadn't been much of an innovator when it came to medical treatments. But when it came to surgery, he was actually really insightful. He did quite a few interesting things with surgery, figured out that nerves control muscles, figured out how you can kind of suture wounds, and he was in fact temporarily a physician at a gladiatorial arena. So if you think about having a chance to see trauma, well, there you go. You can see trauma, pneumothorax, bleeding, internal bleeding, as well as various cuts, gashes, etc. So he was able to use quite a bit of that knowledge practically to carry out anatomical experiments, come up with his humoral theory about how things worked, but like pretty much everybody from the Greeks onward, he really saw the intellectual exploration of things as different from the manual activity. And even though he took a great deal of time and effort to do experiments, it wasn't something he focused on people doing after him because he thought he'd figured it all out. So that idea of experimentation as something worth doing, cutting, investigating, treating by hands, was not something that was really considered to be high status. Now because of that, when we start to get barbers and barber surgeons, they are going to be at a much lower status than the physicians, the people who are prescribing medications, diagnosing, and so forth. Now, in the Islamic empires, where a lot of Western medicine developed after the fall of Rome, surgery had kind of a complicated history because the Islamic scholars at the time interpreted certain passages in the Quran as forbidding the cutting of the body in any way. It was perceived as that was something to avoid. I don't believe that's currently the consensus, but it was conceived of that way at the time. And so surgery was kind of forbidden. However, eye surgery was not seen as being linked with that because it was something that was external. You could kind of deal with that way, trying to remove cataracts by popping the lens out of the way. And one thing that was really a big contribution from the Islamic empires was cautery. So ligation had a little bit of activity in the time of Galen, but cautery was something that really came to be more prominent in the Islamic empires, to the point that ligation was forgotten and cauterizing wounds became the major way that people tried to stop bleeding. Now, one of the big people involved in this was al-Zahari, and he was going to be, or he was in rather, the area that's now Spain, that was called the Andalusian Empire. That was where a lot of the intellectual activity of that caliphate was done, and basically wrote down quite a few things and had an illustrated guide to some of the surgical procedures that were there. So these are actual tools that were used. Now again, you could only kind of skirt the lines of suturing things, cauterizing things. Doing invasive procedures was very strictly frowned upon, but he was able to describe how to treat certain wounds, and it became very influential. And eventually, the only person who rediscovered a more experimental approach after him was going to be in the Middle Ages, named Ambroise Paré. So we'll discuss him in just a little bit as well. So jumping back to the terminology is a little confusing here. Barbers, surgeons, and barber surgeons, depending on what country you're in and at what time you're in, can all mean the same things. So physicians were the people who were doing the hoity-toity advanced diagnosis of disease, prescribing treatments, but they didn't actually do the treatments. And if you were going to have blood drawn, it certainly wasn't going to be the physician who got his hands dirty doing it. So barbers were doing that. And barbers, they drew blood, but they also pulled teeth, gave enemas, and, not surprisingly, cut hair. So we still have that hair cutting aspect of the old barber or barber surgeon out there today. And they added the dressing of wounds to their field. So that's roughly when people start to think of them as barber surgeons, when somebody would come to them for the wound to have wrapped and kind of, treated that way. And because this is an illiterate time, how do you advertise that you are a barber or somebody who can deal with a wound? You can't put a sign out with the word barber on it because nobody speaks or reads the language that well. So you take a pole and you wrap a bloody rag around it, and there we have the origin of the barber pole, basically as an advertising for, hey, are you bleeding? Come on over here. Now, what's interesting is that these barbers and barber surgeons, as people who were actually working with their hands, doing some experiments, they were poised to actually make real contributions and notice problems that existed with the authorities at the time. But the Council of Tours was a council that basically forbade clergy and monks from conducting surgery. And at the time, the only people who could read the works of the old authorities in general were the monastic people. So when you took that literate group out of the equation, you then had barbers and barber surgeons who could only learn by the apprenticeship model. They weren't able to compare their results with what was supposedly true according to the other authorities. And so essentially they became a craft art. And that doesn't mean that they weren't skilled, but they weren't skilled in a way that could build on itself. And they weren't able to really have any means of making their findings known to future generations widely and writing it down. So that's one reason that there was a lot of stagnation in the development of surgery in the Middle Ages at that time. So we have barbers, we have barber surgeons, and I think I mentioned a while ago, in Paris there was a group of surgeons who wanted to emulate the physicians. They wanted higher status. They wanted to make surgery more literate, which to them meant reading Aristotle, reading the contributions from the Islamic scholars who were being translated into Latin. So basically they wanted to be more like the physicians. And so they started wearing a short robe, whereas the barbers became separate from these surgeons by having their academic robes, or their robes period, being short. So it took a while for French surgery to develop, because instead of the barbers becoming literate and doing their work, the literate barbers then just started carrying on the same way that the physicians at the time did, making the authorities of the time still more rigid and not encouraging any sort of innovation. Now, what's interesting is that's what happened in France. English recognition of surgeons and barber surgeons came all at once in the 1500s, and that's going to be when Henry VIII was decided that he was going to have a single guild that would basically define the roles of all these people. And barbers could pull teeth, do bloodletting, cut hair, and shave people, and they got to, in England at least, have a blue and white pole, whereas the academic surgeons had the red and white pole. They were going to do more invasive things, wound healing, and so forth. So there's a little bit of a segregation of what roles were allowed for barbers and barber surgeons, but that was only in England at the time. Now, the Middle Ages is often considered to be a really stagnant period of time, and it's largely unfair. The Middle Ages had a lot of things going on, but the intellectual activity of the time was really focused on working through your knowledge of the authoritative ancient sources rather than finding out new stuff. But there were some things in the Middle Ages that were fairly useful and interesting. We'll talk about Hildegard of Bingen at the next talk. But in terms of surgery, we have a Frenchman, Guy de Chalac, who actually was relatively well suited to adding to the knowledge at the time rather than just aping what had gone before. So at one point, the papacy left Rome and moved to an area of France called Avignon. It's called the Great Schism, and he was the surgeon to 3 of the popes that actually ruled the papacy from the Avignon area of France. And essentially, when the plague came through, he recorded all the things that happened and was able to lay down the 3 different types of plague that seemed to be occurring: the bubonic plague, when it spread through the lymph nodes, the septicemic plague, when it would spread quickly through the blood, and the respiratory version of the pneumonic version of the bubonic plague, where it would actually go through the respiratory tract. He caught the plague, but actually was able to recover and record his experiences with it, and actually advised the Pope at the time to basically seclude himself in his rooms, good idea, and to keep fires burning all the time to burn up whatever sort of miasma was floating through the air. Didn't actually wind up being that useful, but that Pope did get through that period without catching the plague, and so it went, Guy de Chalac's status went up thereafter. So he, unlike most people at the time, was able to write down and convey the things that he'd learned over time. And he did different investigations into how to treat things like ulcers, hernias, fractures, cataracts. Have I mentioned how cataracts were treated when we talked about ancient medicine? Anybody remember? So basically, cataracts are a cloudiness or a darkening of your lens, and so you can't see. So how do you treat that in ancient times? Well, you're not really able to cut into the eye too easily, but what you can do is use a blunt probe and hold somebody down and basically pop the lens into the posterior chamber of the eye, at which point you can no longer focus light, but instead of nothing, now you can see shapes, you can see shadows, and it's better than being completely blinded by the cataracts. So that was an example of some of the surgeries that were being done. But a lot of surgeries at the time were, let's say, misinformed about how effective certain treatments would be. Take hernias. We haven't talked, if you're a first year, about hernias yet, but basically a hernia can be, one way it manifests largely in men, is a loop of intestine that moves down into the scrotum. Now we think, oh, let's move the intestines back up in there. But back in the olden days, you know what the major treatment for hernias was? Castration. And that solves literally none of the problems and makes plenty of others along the way. So yeah, the ideas, there were bright spots like Guy de Chalac, but they were still misinformed by a poor understanding of human structure and anatomy. So he was very familiar with the ancient sources and Galen, Al-Zahari, etc., but he did want to try to improve on things. Now, no one's perfect, and he did maintain one error of Galen's that was going to be a major problem for most of history and surgery, and that was the idea of called laudable pus. Now, laudable means praiseworthy, and the idea was that if you did a procedure on somebody and they had a cut, and you sutured it, or you did an invasive procedure, that pus was necessary for healing. And the problem with this is, some pus is going to be staphylococcal pus. It's going to be thick, it doesn't spread too centrally, tends to heal up all right, but other pus coming from other microorganisms can actually be deadly. The main problem with that is, if these guys were somehow able to suture somebody up and it healed so well on first intention that there was no pus, they would open it back up because they thought the pus was necessary for the process of healing. So you can imagine some people dodged a bullet only to be hit by another bullet when the surgeon reopened that wound and they got infected thereafter. So, moving forward, still in France, we have, it's hard to call him the first modern surgeon, but the first real surgeon of note in the modern cast was called Ambroise Paré. And Ambroise Paré basically made surgery into a respectable field in France. Over the course of his life, it became fairly respectable because basically he was locked out of getting into the long-robed academic surgical appointments. He didn't speak Latin. He didn't have a university education, so he did what a lot of people did when they were kind of unable to pursue their main course, is he joined the army and became a barber in the army that way. So it was another way for him to train without needing to go through the university. So he trained as one of the low-class barbers, yet even despite their low status, they were considered, well, they, by our standards, would be considered the most capable because they actually had experiences. They did things. And so he was unable to join the academic surgeons, joined the French army, and essentially he came up with multiple refinements on surgical procedures and kind of started an investigative method of dealing with surgery. Now this is fairly new. He actually would investigate new ways, compare how things went, and then modify his results accordingly. He didn't start with the idea that the treatment was already settled. He tried to find better and new treatments and actually, can't quite say scientifically, but see how the results matched. And the thing that set him off on this is really kind of a cool story. Back when he was in the army, firearms had just been introduced to warfare, and so dealing with projectiles and firearm wounds was brand new. And so the wisdom at the time, wisdom in massive red font with quotation marks around it, was that the bullets were dangerous and the actual things that got lodged in your body were dangerous, but that the main danger was from gunshot poison caused by the gunpowder. So the idea was that the gunpowder poison was more deadly than the actual projectile that would hit someone. So instead of pulling the bullet out, the main focus of the surgeons treating people with gunshot was to pour boiling oil into the wound as soon as possible. This didn't go very well. But these people were hit by gunshots, so if they die, is the surgeon going to blame himself, or is he going to blame the fact that this person just got hit by a bullet? Obviously the latter. Paré was doing his job, he was treating them the normal way, and he ran out of oil. He ran out of the things he needed to actually treat the patients. And so in kind of desperation, he came up with a poultice based on, he basically took some egg whites, some spices, some other things, and patched it up, and basically he was distraught thinking, oh, I've totally killed these guys. I've not neutralized the gunpowder poisons, I just did the best thing I could. But he noticed something over the next couple days that to us wouldn't be surprising at all. It's that the people he treated got better, whereas the people who were treated with the boiling oil invariably died due to the additional trauma that was caused by the treatment. Now, he obviously didn't know about lysozymes and other things in the egg whites that would actually help combat bacteria, but he noted it and he didn't drop it. He kept pushing for new ways to improve surgical procedures. So he's basically kind of like the Vesalius of surgery in that he didn't just go along with what was before. When he noticed an innovation, he knew what it was. And he started intensively investigating new ways to treat people throughout his life. He wrote lots of books. He was definitely not modest. The books definitely lay out that he thinks that he is definitely the best thing that ever happened in surgery, but he backed it up fairly well. He had surgical research going. One of his books is here, and again, this is it's a book, so it's intended for a literate audience, but advertising being what it is, you want to get the most bang for your buck. So how do you advertise a surgical book? You show all the injuries you'll know how to treat afterwards. This is called a wound man, but it's basically an advertisement for, hey, do you need to treat people with a dagger to the eye? Check this book. How about a club to the knee? Check this book. Spear to the foot? Check this book. So that's where that kind of comes from. So in addition to that initial treatment, he reintroduced the idea of ligatures rather than cauterizing, which in like boiling oil can be very traumatic, especially if it's not applied at the right time and place. He used them to, during amputations. He investigated other diseases like syphilis, dislocations, and looked at how you could actually put dislocated bones back into place rather than just leaving them there, and basically stopped that idea that it was a good idea to castrate someone during hernia repair. So he noticed when things weren't working, and he actually made a change in his work based on that. And he was very well liked because of that. The soldiers knew that he actually could help them as opposed to a lot of the other people. And at one point, the French were besieged, and they smuggled him into the city to treat the soldiers there. And they actually carried him around town in triumph because they were so happy that he'd actually gotten there. So, the life of Ambrose Paré is very interesting, but it does bring up something that's really pretty common. Sadly common, but it's that war and surgery really go together. War and new advances in how to kill people more quickly, more efficiently, brings medicine, and especially surgery, up to higher and higher levels of efficacy because you have to find ways to treat people who've been damaged in new and horrific ways. So essentially, once the idea was that you actually had to treat your soldiers, surgery started developing akin to that. Now, back in ancient times, if you were wounded on the battlefield, you were probably, just out of luck. You would hopefully be killed mercifully by someone, but yeah, there was really no interest in trying to triage people, save those who were only wounded but might recover. It was basically tough luck, and you're going to be left on the battlefield to die at whatever point you do. So in the 1500s, Paré introduced arterial ligature, making it easier to control bleeding and do amputations that actually worked. In the Revolutionary Wars, we mentioned Washington introduced smallpox inoculations that actually made the Revolutionary Army a little more healthy and able to maintain their fighting ability, which may have prolonged the war to the point where the British finally gave up and the American Revolution succeeded. Now, in the 1850s, during the Crimean War, Florence Nightingale made nursing much more rigorous and much more hygienic, and made basically nursing, which was a very suspect and poorly regulated, poorly thought of profession, something that was a lot more high status and something that was a lot more rigorous afterwards. Now, during the American Civil War, quick jump ahead, anesthesia actually exists. When you think about all the amputations in the Civil War, you think about people having that done under anesthesia. It's not because no one knew how to do anesthesia, it's just that there wasn't enough anesthetic near the battlefields to make it practical. But hospitals and hygiene standards were actually introduced during the Civil War, which made it a little bit possible to transport patients to a hospital and hope that they would survive thereafter. Now, in the 1870s, the Franco-Prussian War, vaccination was actually used to stop disease. So we used inoculation with smallpox. Now we've actually got smallpox vaccinations helping to keep the disease down. And in the aftermath of World War I, reconstructive surgery began to really take off. The ability to actually make prosthetics, make facial prostheses that would actually allow people to interact, that was something that came out after the injuries caused in World War I. And then the 1950s and 70s, during the Korean and Vietnamese wars, rapid transport and the ability to get people to staged hospitals more quickly allowed people to actually be treated for wounds that otherwise would have been fatal in earlier eras. Limb reattachment, neurovascular repair was something that came to be known, and PTSD, known prior as shell shock, battle fatigue, and other kind of euphemisms, was something that was diagnosed as a real entity and not something that was just due to a weak will or someone just trying to get out of service, but it was noted to be an actual psychiatric disorder brought on by the stresses of war. And currently, the wars in Iraq and Afghanistan have done a great deal for us to understand neurologic damage and how things like improvised explosives can actually cause neurologic damage even if you're not immediately injured by the blast. The concussive force can cause diffuse axonal injury, concussions, contusions, and more. So war is nasty, but surgery almost always, and medicine always tries to find ways to cope with that. So one problem in war that doesn't always impact surgery directly, but will impact the ability of people to heal after surgery is hygiene. And I have a quick question for you guys. What's the first American war where we lost more soldiers to the actual battle than to hygienic conditions or food-related causes. Take a second, consult with your table, and then just shout out some answers. All right, do we have anybody want to throw one out there? It's a lot of discussion. Come on, somebody shout. Go for it. The Civil War, okay. Any other options? 1860s, 1870s Civil War, any others? There hasn't been one. Good answer, okay. Anybody? World War II, okay, so 1940s. There is actually an answer, and the answer is the first Gulf War, 1990s. Yeah. I was in high school. I was alive for this. The older you get, the more you become history. Buckle up, people. All right. So, because Ambroise Paré was such a distinguished surgeon, because his results were so good, the French king basically told the academic surgeons, this guy is on par, if not superior to you. Let him in. They waived their Latin exam, and he became, on par socially with the other high-status surgeons. Now, if I could go back in time, there's lots of places I'd visit, but one of them is right here. So, the French King Henry II was fatally and not instantaneously killed when he was jousting at some celebrations that were being held to celebrate the marriage of his daughter his daughter to King Philip II of Spain. And so he had a lance pierce his visor and actually go into his skull, but it didn't kill him right away. And so they're in France. So Henry II, obviously Ambrose Paré is sent for to see if he can figure out what's wrong with the king. And so they see that the lance has actually penetrated his skull. He's not convinced that it's actually going to work to treat him, but he wants to find a way. So they take several heads of executed criminals, replicate the injury, see if there's some way for them to treat it, and they're unable to do that. But the person helping him do this is one of the physicians to Philip II, King of Spain. It'd be Andreas Vesalius, was consulting with Paré in the same room to see if they could find a way to heal Henry II. Now, the wound was pretty massive, and post-injury infection came in, and he did die. But you got the two of those in the same room. So if I ever get a time machine, maybe I'll try to be that guy right there. If any of these people strike an instance to me, you'll know I was successful. So surgeons in France had a very slow road to respectability, and the same was very similar in England. They were chartered together by Henry VIII, and Henry VIII, if you don't know much about English history, but you think famous British king, you're probably thinking of this guy. He's the one with all the wives and the executions. And essentially, he said, okay, we're just going to charter everybody because everybody has their own roles, and leave it at that. And the English surgeons, all of them, received 2 bodies per year to dissect for their studies. The Scottish barber surgeons only got 1 body per year, but bizarrely and amazingly were given the right to have the monopoly to distribute whiskey in Edinburgh. And if you're distributing whiskey in Edinburgh, you're going to be doing pretty well for yourself. So, speaking of Edinburgh, Edinburgh became a major hub for anatomical and surgical research, and the universities in Scotland really did start to excel at investigating new and interesting treatments, finding new structures, describing existing structures better. But to do so, they had to have bodies to work on. And you just saw the surgeons in England got 2, in Scotland, Edinburgh at least, they got 1. So what are you going to do? What they did was turn to body snatching. The surgeons themselves were gaining respectability, so they're not necessarily going to be the ones who would go out and dig up bodies and bring them back to the schools afterwards, but they would hire people to do that called resurrection men. And I don't know why this is so amazing to me, but I was floored I guess I like clever solutions to weird problems, but basically I always thought, man, it'd take forever to dig up a body, but then you read a description of it like, no, they just dig a small hole near the head, break the casket, and lift the person out by their shoulders, and then be done with it. So, very efficient method to get through there. Now, the Edinburgh had something very interesting, was they had a family that held the chair of surgery, of anatomy there for 126 years. So they basically had a family that did that. So they would have people bring in bodies that were, stolen. They would teach the students with those. And they actually had these guys teaching. So you had Alexander Monroe the First, who was very innovative. His son Alexander Monroe II, who was actually even more innovative, did a lot of good stuff. And Alexander Monroe III, who was considered to be the worst teacher imaginable, very dirty, just referred to his dad's and granddad's notes, just read from them, didn't like to lecture. He'd actually leave lecture midway through if the students got irritated with him. And he actually taught Charles Darwin, and Charles Darwin has, there's letters of his that are describing just how much he hates learning anatomy from this guy. So, yeah, I'm trying to think of movie trilogies that start that way. Good, better, terrible, and maybe some of the X-Men movies would be there. So, okay, I had to get something geeky into the lecture as we go. So, obviously, people are not going to be happy that these surgeons and other people are stealing bodies. And so they would create things like these. They'd have what were called mort safes. They would actually have cages around recently buried caskets, and they would stay there for several weeks until the body would no longer be usable. There were actually patents for things that would fire shotguns at people digging into the ground, and there were also bells and traps that would set off if people kind of tripped them as they were moving through the cemetery. Now, burking became another method for getting bodies, and it's called that because of Burke and Hare. Now, it takes a lot of work to go dig up bodies in a cemetery. So Burke and Hare, they kind of oversaw an inn, and one of their elderly patrons died before paying his bills. So they took the guy to the anatomists and, surprise, surprise, made a ton of money compared to what they were expecting. So what do two enterprising and completely morally bankrupt people start doing? They just start murdering people who are staying at the inn and selling them to the anatomical schools that are not asking too many questions or looking too rigorously at where their supply is coming from. And by the way, there is a comedy starring Andy Serkis and Simon Pegg called Burke and Hare. It's completely inappropriate and hilarious, so feel free to check that out when you get a chance. However, this couldn't last, and in fact, they murdered a well-known kind of a street person in Edinburgh who was pretty well known to everybody, and the students at the surgical school were like, why are we dissecting him? I saw him like 2 days ago, like what's going on? So it was basically, the game was up. Hare turned state's evidence against Burke. Burke was executed, and in a little twist of irony, Burke's skeleton was then given to the surgical school in Edinburgh, and his skeleton hangs there to this day, and they bound books out of his skin. That's one in the middle right there as well, and on the inside it's inscribed, bound in the skin of murderer Burke. So there we go. So that's pretty crazy. Buckle up, it gets even better. So here we go. The two big names in Scotland and England for surgical investigation are going to be William and John Hunter, two brothers. And surgery, again, retained that taint of being manual labor. It wasn't seen as on par with the activities that were done by physicians. But over the life of John Hunter, that did not switch, but surgery became as well thought of, as scientifically rigorous, and probably more so scientifically rigorous than medicine, and socially equivalent to it. Now, it's sometimes tough for us to think about surgery being a low-status profession because we live in the time we live in when surgeons are considered to be, pretty affluent, pretty well-respected people. Has anyone here been an EMT? Got several EMTs. As an EMT, you're doing your best to save people's lives. Did you ever feel like you were granted the respect that such a position is probably owed? Did you feel an overwhelming amount of respect from friends, family, and colleagues when you said that you're an EMT? I see heads shaking. Yeah, so EMTs are good people. They're trying to save us, and yet there's this kind of suspect, like, oh gosh, don't let these people touch me thing going on. So imagine one super amazing EMT coming along, and by the end of his life, everyone's like, I can't wait for my child to become an EMT. I am so proud. It's the best thing that could ever happen. That's basically what happened to surgery with the life of John Hunter. So William Hunter, his older brother, basically moved to London, became an OB-GYN, and it was at the time called male midwife, but he also opened up an anatomy school. Anatomy was fairly poorly taught at the universities at the time, and so he actually opened up a separate anatomy school that was not part of any university, but medical students from other schools would come take his anatomy class because it was so much better than anything they were getting at their lectures with probably no anatomical dissection at their existing school. And it went really well. He was making a great deal of money and a great deal of impact as an anatomy teacher as well as a physician, or surgeon, I should say, and things were going so well, he needed his brother to come help him. And they really didn't know what to do with John Hunter. John Hunter was a very bright kid, but he never did well in school. He went to university for a semester and it was a disaster because he hated learning Latin. He didn't want to take all the prerequisites, and he just wanted to go wander around the fields, examine the animals, examine the plants, just find anything he could and just delve into it. So his brother said, well, we'll bring John down. I'll make him one of my anatomy assistants. He'll learn a trade. It'll be worthwhile. And so John Hunter came down and started helping procure the bodies and do the dissections. And it turned out he was really good at it. He was really good and really methodical at examining the structures of the bodies that he was working in. And eventually he decided he did want to reach a little bit higher, but going to university was not going to be in the cards for him. So he did what Ambrose Paré did. He joined the military and became a military surgeon. And because of his really just unquenchable desire to know more and more and more, he was a good surgeon because he knew what he was doing, but he kept on investigating ways to do better and find new anatomical features, find new ways to solve existing problems. So he then returned after his tour with the Army and trained in the hospitals under the leading surgeons at the time, people named William Chesterton and Percival Pott. They were kind of the early lights in improvement of surgery in England at the time, working on lithotomy, removing stones from the bladder in a far more effective way than going through the perineum, as well as orthopedics and dealing with fractures and dislocations. So John Hunter eventually took over the anatomy school that his brother had started, and he worked just tirelessly. He worked all the time dissecting, visiting patients, doing hospital call, teaching his students who were house students there, and just dissecting not just human bodies, but any animal he could get a hold of. He told all the menageries and all the circuses that if their animal passed, he wanted it so he could dissect it, understand how it worked. He actually, when he was later in life doing rather well off financially, he bought a country house and just basically had every weird exotic animal he could get a hold of there, and when he didn't kill them, but when the animals did die, he would then dissect them and preserve their bodies, check out their organs. And he had leopards, and he had oxen, and he had all kinds of crazy animals there. And anybody know who Dr. Dolittle is? Familiar with that? The guy who wrote Dr. Dolittle lived in that same town, and it's theorized he basically was taking Dr. Dolittle from John Hunter and all the crazy animals that were living on his land. So John Hunter is a personal hero of mine because he was just so ravenous for knowledge and worked so hard and did so many things. But he's really morally very ambiguous because the things he would do to get interesting specimens are just horrific. So the picture on the right, that's the picture of a guy named Charles Byrne, pardon me. He was known as the Irish Giant. Now, if you were somebody with gigantism back in those days, you didn't have athletics to go to. You didn't have any way to really make a living other than displaying yourself in a sideshow. And so people would come to see him and they'd charge him. So he was basically like a circus sideshow feature. John Hunter went to the exhibit and basically said, "You're amazing. when you die, I really want to have your body so I can dissect it. John Hunter was not the most canny or tactful of people, and so I can only imagine how that message was delivered. And so Charles Byrne, who was a good Catholic and thought that his body had to be whole when the day of resurrection came, was absolutely horrified at this. And as his health started to slip, and his health got worse and worse due to his condition as well as alcoholism that he picked up, he knew that John Hunter was going to be coming for his body. So he used the last of his funds to buy a stone coffin and have his body put in the stone coffin and dumped in the sea. John Hunter counter-bribed the undertaker, and so as they were taking it to the sea, they stopped at a pub for the night, and the undertaker came out, unlocked it, John Hunter got the body, replaced it with some rocks, and pretty soon the skeleton was back in his school, and there it remains. So he would do anything to get an interesting specimen, and yeah, I mean, I'm floored by some of the amazing stuff he did, but just the moral ambiguity of it is horrifying and should not be ignored at any cost. But let's go into some of the things he did. He had all those animals at his estate. He was instrumental in founding the Veterinary College of London. He had so many specimens, so many skeletal specimens, so many specimens in a jar, that he actually had a museum in his own home. That's it. He lived there. That's actually where he lived. And that is, again, another career goal of mine. My wife is over there. Please put in a good word for it as we go. But so he was really innovative in so many ways. He described the anatomy of many animals. He wrote a treatise on whales that was the inspiration for Moby Dick. He examined mastodon teeth and came up with the very unpopular idea that animals could actually go extinct. At the time, the theory was nothing new had come into existence and nothing had ever gone out of existence. But the idea that something could go extinct was something he put forward. He anticipated natural selection in one of his writings, but the Royal Society of Surgeons did not choose to print that until after Darwin had printed on the origin of species. And so you got to give Darwin his credit. Hunter did not anticipate everything Charles Darwin did, but he did discuss how changing forms of animals could be permutations from a common origin. So he investigated everything he could relentlessly, but again, on the weird side, he was very keen on finding out what he could through any means possible, and that included auto-experimentation. Now, at the time, people knew that syphilis was a disease and chlamydia was a disease, but there was a huge debate as to whether syphilis and chlamydia were one disease that manifested multiple ways or two separate diseases. And so Hunter decided he was going to figure it out. And so he gave himself syphilis. He talked to a sailor who had syphilis and agreed that the guy would take some of the syphilitic pustules. Hunter would collect it, scraped his arm, gave himself syphilis, and broke out with a case of it, as well as chlamydia. So he said, oh, they're the same disease. Unfortunately for him, the soldier he got the specimen from had both chlamydia and syphilis. So he actually wound up on the wrong side of that debate, and yeah, in the worst possible way of being wrong, gave himself both of those diseases. He investigated tendon repair because one night he was doing jumping jacks to stay awake while he was writing, and his Achilles heel snapped. And unlike most of us who would think, oh, I have to rest for a while, he thought, wow, how does that thing heal? So he started doing experiments on animals and seeing how tendons healed, tracked how that worked, etc. One thing before I get into how he died, he also is the person who gave us the nomenclature we use for our teeth these days. When we talk about cusps, bicuspid, incisor, he came up with that designation and actually was helpful in getting the first dental college founded in England. Now, dentistry was at a far, far lower level even than surgery at the time, so the fact that he was willing to help veterinarians and dentists investigate their field and improve it just says a lot about him. He wasn't really concerned about the status as much as the knowledge. And so he was suffering from angina, and he knew enough to know that he was eventually going to have a heart attack and die. And he was having an argument with some of the administrators at his hospital about who was being assigned where, and in the middle of it, he started having a heart attack. He felt the clenching in his chest, and so what did he do? He ran to a mirror and started writing down the appearance of his face, the appearance of the symptoms, and that's where he dropped dead. So lived and died just the same way. So that's how John Hunter made surgery respectable as a social aspect, a social activity in England. In France, it happened all at once. And it happened all at once because of this guy. Now again, if you're not into history, but you think famous French king, you're probably thinking of this guy, Louis XIV. He was the Sun King. He ruled for a tremendously long time, and he was basically the model for absolute monarchy in Europe. And his life was just miserable medically. He had a lot of different medical conditions, no doubt brought on by the rich food, the sedentary lifestyle, and the fact that he is reputed to have bathed twice in his life, once being his baptism. It's actually, now, when you smell bad by 1700 standards, just wow. I mean, it said people would run out of the room when he came in. It smelled that bad, so go figure. But when you're the king, I guess you can deal with it. One of his medical maladies was an anal fistula. Now, what's an anal fistula? My children are here also. Hi, guys. Basically what happens is an anal fistula is when you have an infection in your rectum and it creates a secondary passage that exits alongside your anus. So basically you've got an inflamed, infected opening alongside the anus, and Louis XIV had one of these. He didn't like having one of these. It was very painful. It was probably going to get infected and kill him eventually. So he told the court surgeon, a guy named Charles Francois Felix, that he needed to come up with a way to treat it and do the procedure on him and cure him of the anal fistula. So Felix had to come up with a way to treat this condition, a condition in an area that is absolutely not hygienic. Even though we don't know about germ theory, it's not going to be an easy area to heal. It's not going to be an easy area to do a procedure on. So Felix actually started doing surgeries on peasants who had anal fistulas, and actually some who didn't, to try to come up with a way to cure the King of France. And he came up with a procedure, but none of his subjects survived it. The day comes, and he has to work on the King of France. You can only imagine how I would have had a horse ready to get me out of town as quickly as possible. But he does the procedure, and Louis XIV survived. Now, Louis XIV not only survived, he then said, okay, these surgeons are all right. I'm going to charter them right now, and they're of equal status as physicians, and every detachment in the army will have a surgeon working with them hereafter. So in one fell stroke, by royal decree, surgery was respectable. Now, my personal feeling is Felix probably came up with the procedure fairly well in his process of developing it, but the one thing he wouldn't have taken account of is germ theory. Now, before you do a procedure on the King of France's anus, what are you likely to do with your tools? You're going to wash them. They're actually going to be clean. So there was actually probably enough hygienic consideration taken, not because of germ theory, but because of decorum, that it might have saved the king's life. So essentially, the surgeons got to set their own standards, make sure that they were a profession that was actually able to self-regulate. And when the French Revolution came along, they basically got rid of all distinctions between physicians and surgeons, and just everybody was considered to be a health officer at that time. So surgery had a much more rapid increase in status in France. Now, despite the fact that surgery had gained prestige, as well as a fundamentally decent basis of anatomy to operate from, it was still a really brutal and nasty affair. It was still just terrible because there was no anesthetic. People would be awake for and cognizant of everything happening during the procedure, and after the procedure, there's a really good chance they would die of an infection because of the post-surgical, just complete lack of knowledge about germs that could be infecting the wound after the surgery, during the surgery, and how to properly dress the wounds to prevent that. So surgery was still something that people avoided at all costs, because going to the surgeon was basically saying, I've had a good life, I might as well give this a try because my condition is so terrible, I'd rather gamble on dying in this procedure than actually continue living. And how did that change? First thing that changed was going to be the introduction of anesthesia. And I think it's a good time to take a quick little break, so quick intermission for 5 minutes here, grab some more food, use the restroom, and we'll come back and discuss how the two big impediments to surgery, anesthetics and antisepsis, the first big promotions of them were put forward and made surgery into its more modern, effective state. go ahead and start up again. So we're going to start tracing how modern surgery developed by looking at how anesthetics developed. Now, from time immemorial, from the Egyptians on, we've had alcohol, opium, as things that could dull the senses, but they were never really that good at completely putting someone under so that you could do a surgical procedure without having them react to it. And so the main thing that surgeons tried to develop was speed. They tried to do the procedures very, very quickly, just because it was painful. You needed to have people holding down your patient for you to actually accomplish the procedure. And there are actually descriptions of patients overpowering the orderlies and running down the hallway with their bodies and organs kind of hanging out to get away from the surgeon. So in 1807, there's another French military surgeon. Again, war and surgery tend to go together. Dominique Larrey had to do a huge number of amputations over a 24-hour period. He had to do 200 amputations of soldiers during the French-Russian battle at Borodino. And as he got further and further along, he noticed that the amputations got easier, and it was because the people who had been waiting had been out in the cold, icy environment, and their legs or other limbs had been numbed by that ice, and so he was actually able to do the procedure more easily. So he actually thought that he could use ice as a way to dull the pain, so he'd actually try to get people chilled down, chill the area that was affected before doing the amputation. And that was a pretty decent insight. He also introduced the horse-drawn ambulance to actually get people off the battlefield. So one of the first evidences of deliberate triage and removal of soldiers from the battlefield was due to Larrey as well. Now, actual modern anesthesia is one of the best stories, and this story is literally the one, when I first heard it, that kicked off this series of lectures, because I heard this story and said, I have to tell others. This is too insane. So my interest in medical history comes from this exact story here. And congratulations us, this is the first American contribution to medicine and surgery that really had a massive global impact. And yet it had nothing but misery for the people who were involved in its discovery. So back in the 1800s, we didn't have TV. Theater was very infrequent. You didn't have the ability to listen to music on demand. So people did what they had to do to enjoy themselves. And one thing they did was go to laughing gas parties. And basically somebody would make a bunch of nitrous oxide, and you and your friends would huff and puff the nitrous oxide, get silly, laugh around, everybody would have a grand old time. And at one of these, a dentist named Horace Wells, the most consistent version of it that I've seen is that he took the laughing gas and on his way back to his chair just rammed his knee into another chair, but didn't feel any pain. In fact, didn't really know that he'd hurt his knee until the next day. Being a dentist, he thought, I wonder if I could do something like that while I'm pulling teeth. And so he started working on pulling teeth with nitrous oxide, and it worked really pretty well. It was a little tough to titrate how much to give people and when to do the procedure, but it worked all right. So he thought, well, I wonder if it could be used for something else, maybe surgery. So he talked to the head surgeon at Boston General Hospital, a guy named John Collins Warren, really well-respected surgeon. And honestly, Warren could have just told this guy, get lost. He was incredibly well thought of, but he'd never quite lost his humanity despite these years of just screaming and horrible outcomes and terrible traumatic procedures. He still wanted to help his patients feel better. So when this guy came to him and said, we might have a way to do painless surgery, he was willing to give it a try. Sadly, on the day of the procedure, the patient backed out. And so in the middle of the medical amphitheater, Horace Wells just asked, is there anybody here who's got a bad tooth? I could remove the tooth under anesthesia and you could, we'll see if that works. So one of the medical students volunteered, and the story goes that the student who had the tooth pulled let out a yelp when the tooth was removed, but later said he actually didn't feel any pain, but there was kind of an involuntary kind of noise, but that was enough. Now, you guys get lectured to about professionalism and being good people all the time. That's a relatively new development. Medical students had a very historical and long-lived and well-deserved reputation for being very boisterous and obnoxious. And so they just started heaping abuse on this guy who was in the middle of the surgical amphitheater trying to demonstrate this. And apparently as he fled the amphitheater in disgrace, the thing he heard that really hurt him the most was humbug. So I think humbug needs to make a comeback as a general term of derision. So many others are problematic. I think humbug is one we can all get behind. So a student of Wells, however, knew that this was worthwhile, and he thought that there was still something to this. It needed to be explored. And this guy, William Morton, had similar experiences at a similar event called an ether frolic, which is exactly what you might think it is. It's where you sniff ether and get silly with your friends, and everybody has a good, funny time, and then that's that. So he started investigating using ether as an anesthetic for dental procedures, and it worked better than nitrous oxide. And he actually was able to talk Dr. Warren into allowing him to attempt the same thing in front of a bunch of the same students, no doubt, to actually do surgical anesthesia on one of his patients. And so almost a year to the date from Horace Wells being, shouted out of the room, William Morton comes in. He'd put together an apparatus at the last minute to try to control the flow of ether through a sponge. And in this case, the patient didn't back out. The patient had a large salivary gland tumor that was going to take a long time to take out. Now, just imagine doing a long procedure on someone's head when they're conscious and in pain, and even if they're trying to be compliant, they're going to jerk and twitch and yell. So he administered the ether, the patient went out, and John Collins Warren did the procedure. It took around 20 minutes, and the patient never moved. And in fact, when the patient woke up, he was reported to say, "When do we start?" And so, immediately, this was something everyone realized was a game changer. This was something spectacular. This was painless surgery. And John Collins Warren addressed the students in the room, "Gentlemen, this is no humbug." So once again, humbug needs to come back. Now, at this point, had people behaved themselves, we could have the greatest success story of early American medicine on our hands. However, William Morton had a history, before becoming a dentist, of being a con man, of jumping from town to town, taking out credit, spending it, running away. At one point, he actually tried to get married to a wealthy business owner's daughter. She was Jewish, so he actually agreed to get circumcised, but he was found out beforehand, but underwent the circumcision anyway, but had to get chased out of town when it was realized he was actually a fraud. So he wanted to make money at this. The problem is, ether's a thing everyone knows about. It's not a thing that he invented. So he tried to come up with ways to disguise the fact that this stuff was ether, and they came up with a term for it called lithion. And at this point, a guy named Charles Jackson, who was a Harvard chemist, approached him and said, "Listen, I'm the one who helped you get this ether in the first place. I'm the one who told you how to produce it, how to create it, how to kind of titrate it. I want credit for this discovery as well." Now, Charles Jackson was a weird guy. He was very brilliant, but he was pathologically afraid of being left out of the glory for a big discovery. He thought that he discovered Morse code, not Samuel Morse, in the way that you use telegraphs to send signals. He thought that he had come up with TNT before Alfred Nobel, basically creating dynamite. So he was on the lookout for anything he could latch onto and say, "This is mine, I created it." And so these two tried to work together briefly, but basically just started sparring with each other publicly and just demanding they had priority, not the other, wrote lots of articles, infringed on each other's trademark because they both knew it was ether, even though they were publicly going through the lie that it was something else called lithion. And this became such a massive embarrassment that the US government put up a $100,000 prize in 1870s dollars for whoever could prove precedent. So William Morton got hurried, it was a summer day, very hot. He got into his horse-drawn carriage and went to Washington to try to press his case. But he had a stroke along the way and kind of jumped out and fell into a river. He was retrieved, but he never really recovered and died shortly, well, he never recovered, he died shortly thereafter and was buried in Cambridge, Massachusetts. Now, I've only found one version of this, but it's the version I'm going to tell you because it's the one I like the best. Sherwin Nuland, who was a medical historian and surgeon at Yale, said that Charles Jackson, years later, was at a funeral in Cambridge and saw Morton's tombstone. This man that he despised with every fiber of his being. And what did his tombstone say? It said, "William Morton, inventor and revealer of aesthetic inhalation, by whom pain in surgery was averted and annulled, before whom in all time surgery was agony." According to Newland, Jackson went acutely psychotic at that moment and never recovered, dying in an asylum many years thereafter, and is in fact buried in the same cemetery. So next time you're in Cambridge, feel free to go check out the graves of these two horrendously just competitive people. I'm going to back up just a little bit. I took this slide out, but the other sad side of this is Horace Wells, the dentist who had come up with the idea for nitrous oxide in the first place, knew that he'd been surpassed, but he started using chloroform as another way to do surgical anesthesia, and he started sniffing chloroform regularly and started kind of going out of his mind. And he was arrested in New York for splashing acid on the face of some women who were walking by and was thrown into jail. And he was able to talk or bribe the guards to let him get a packet in from a friend, and the packet contained chloroform and a razor. And so he dosed himself and opened up his femoral arteries and died in jail, kind of a broken man who'd been denied the kind of glory for being the first person to conceptualize the idea of surgical anesthesia at all. Now, if that weren't enough, 4 years before that initial demonstration by Morton that succeeded, it turns out that a rural doctor in Georgia named Crawford Long had actually done ether anesthesia to remove small growths and do some small amputations in his patients. He didn't really think it was a big deal, and it wasn't until the $100,000 prize had been announced that his friends were kind of bugging him like, you really need to tell people that you've been doing this. It's $100,000. But he was content to continue his work. He wasn't really interested in the glory. And of all the people involved in this, he's the only one who kind of died with any real dignity. He actually died delivering a baby, felt that he was going down, handed the baby off to the nurse, and dropped dead. Despite not having publicized it, he was likely the first person to have done that ether anesthesia up until that point. Now, obviously, people who knew that ether had been used knew that it was a huge surgical step forward, and word of this spread to England, Scotland, and other places immediately. And so what's interesting is as people are trying to disguise the fact that it's ether in America, the use of ether in England took off immediately. And one reason it took off was because of Robert Liston. So Dr. Liston was in Edinburgh. He was actually contemporary with the anatomists who were employing Burke and Hare to steal bodies. And he was a really interesting person. He was really tall, really imposing, spoke with a huge booming voice, and he really tried to find things that would make surgery better. He really was an innovator, despite the fact he was renowned as one of the fastest surgeons in the world. He would actually have people time him when he would conduct an operation. He'd give people nudge, so like, start your watches, gentlemen, let's see how quickly I do this. So he was able to do speedy amputations. Apparently he took off an entire lower limb in 2.5 minutes one time. And problems would occur due to speed because occasionally he would take off the fingers of his assistants if they weren't quick enough to get away. The way that the procedure was done at the time was basically they clamped let's pick the lower limb, they clamped the femoral artery, they had people holding down the patient. The surgeon would then take a falciform knife, which is basically a long sickle-shaped knife, wrap his arm around the leg, and make a deep circular cut as quick as he could, grab a saw through the femur, take a flap of skin, and suture it back. And that was the procedure that was employed at the time. So he was renowned as one of the fastest surgeons in the world, yet he still looked for new ways to actually make surgery better. Oh, before I go ahead, does anyone want to hear about the surgical procedure that had a 300% mortality rate? All right, so Liston was doing a procedure, lower limb amputation. As he did so, he cut into the patient. His assistant, who wasn't well trained, didn't move fast enough, had 2 of his fingers taken off. As the patient and the assistant screamed and jumped, Liston jerked back, and his knife went flying towards the audience. Didn't actually hurt anyone, except there was an elderly gentleman in the front row who had a heart attack and died as the knife got close to him. And then the patient and the assistant succumbed to post-surgical infection. So 1 procedure, 3 dead patients, or 3 dead people. Now, despite that, Liston was actually looking to find ways to make surgery better. He looked at ways of using mesmerism to make people insensible to pain during surgery, and it actually worked, but it took hours and hours of a mesmerist to kind of put someone into what we'd think of as a hypnotic state where they wouldn't feel or react to the pain. But when he used the ether, he knew right away that it worked wonderfully. So he used that right away, and it's not quite humbug, but I really love the thing he told his students. This Yankee Dodge beats mesmerism hollow. Translation, this American gimmick is way better than hypnosis. So there we go. Now, one other thing about Liston before we go is Robert Knox was the anatomist who received the bodies from Burke and Hare. Liston actually got into a fist fight with him during a lecture. So just imagine one of the other professors in here running up and punching me in the face, and that'll be basically the same level of shock that these students would have had. And the reason is he discovered that a female patient of his had actually been killed by Burke and Hare and used in Knox's anatomy school afterwards. So he was a little bit upset about that. Now, another innovator is a guy named James Simpson, who started looking for things other than ether. Now, ether, it's a little bit irritating, and it's very difficult to titrate. They had a really tough time figuring out exactly how under someone needed to be before a procedure could take place. So Simpson was looking for other things, and one of the things he hit on was chloroform. Now, back in the day, before IRB, before research protocols, you could just do whatever. So he would get some friends together and they would just sniff various organic compounds and see what happened. They got to chloroform, and the story goes, they sniffed the chloroform and then they woke up under the table. And then they basically aired out the room and said, okay, this is worth looking into. And chloroform was less irritating, more easy to titrate, and it was something that they were able to use much more easily than ether, and it actually started being used to dull the pain of childbirth. And now, ether and chloroform are flammable. They have to be treated carefully. But there were some other problems that people saw in regard to this, and one of them that was interesting in regard to childbirth is that some of the clergy in the Church of England said that women are supposed to bring children into the world in pain. It's in the Bible, you shall bear these children in pain, and that it did rob God of the deep and earnest cries of a mother in labor. So any woman in the room who's had a child, feel free to shake your fist at that particular clergy member. But these were objections that people raised to anesthesia. It was changing the relationship of people with the physician and their relationship to pain. Now, all the debate stopped at once, and it stopped all at once again because of a royal. Queen Elizabeth gave birth to one of her children, Prince Leopold, under chloroform anesthesia, said it was fantastic. She'd had very traumatic births prior to that. And so when the Queen says it's okay, it's okay. And if you remember John Snow, the guy who was able to curtail the cholera outbreak, he's actually the surgeon who gave Queen Victoria the chloroform during her delivery of Prince Leopold. So yet another time where John Snow really stepped up and helped us out. So we move from people behaving very badly to one of the very few truly wonderful people in the history of medicine that we can honestly say was not out just for their own glory, but was actually trying to make the world a better place, and did so. So we finally have somebody we can admire non-ironically. Let's enjoy that while we can. This is Joseph Lister. Joseph Lister is the person who figured out the link between germ theory and post-surgical infection and how to actually stop it. So he was a Quaker, and he was basically there when Liston was using anesthesia and was kind of inherited that idea that it was worth pursuing ways to improve surgery, not just doing what had always been done, but trying to find ways to improve it. And as a Quaker, he'd been brought up in a very scientific household. His father was actually a famous microscopist. He solved a problem called chromatic aberration, caused by lenses diffracting different wavelengths of light differently and making the picture blurry. So he grew up with microscopes, which was a very unusual thing for anyone, including medical students at the time. So he started looking at inflamed tissues, looking at what was going on there and why the tissues were having the changes that they did. And he read Louis Pasteur's work about the little germs or animalcules that had caused the wine, the beer, the silk in France to go bad, and how he'd combated that. And he thought to himself that maybe there's something like this going on with infections. And so he took a look at the various types of pus that were forming in the wounds of the patients, and very quickly found that there were indeed these little bacteria there. Now, the laudable pus, the pus that Galen and others had said for years needed to be there, turned out to be what we'd now call Staphylococcus. It stays relatively close to the incision site. It doesn't tend to spread widely, and it does indeed not tend to be fatal as long as it's not compounded with other problems. But the thick, smelly pus that we now would know to be strep, it does move centrally. It does spread and will be fatal over time because the body is unable to stop that spread. And worst was the watery, purulent pus that's going to be caused by an anaerobic bacteria, Clostridium. And this caused gas gangrene and was invariably fatal, causing a lot of tissue damage, stinking, nasty sores and wounds. And he found that these bacteria were unique to the different types of pus. So obviously now we've got a culprit. What do we do next? We try to find a way to fix it. He started looking for an antiseptic substance and did some reading and found that some people had decontaminated a well that had been putrid by using benzene. So basically they took this, it's called carbolic acid at the time, but they took that carbolic acid and he started spraying it on the surgical instruments, spraying it on the wound, spraying it into the air, dipping his hands in it. He went overboard, but at the time that was probably a really good idea. So everything was bathed in this carbolic acid, and his mortalities in his procedures dropped tremendously. He was able to show that his patients would survive to a greater degree. However, as with a lot of innovations, do you think it was picked up right away? The problem here is culture. He was going against everything a surgeon was supposed to be. What was the main attribute you wanted to have as a surgeon if you wanted to get your patients dealt with? You wanted to be fast. Now you're dipping the tools in this stuff. You're taking a break to wash your hands in it. You're spraying it in the air. You're spraying on the wound. You're spreading out the time it takes to do the procedure. And basically, his colleagues just thought this was pointless and really weren't swayed by the evidence that his patients survived at a much higher degree than others. And in fact, one of his major opponents was a very famous surgeon in America called Dr. Samuel Gross. There's a very famous painting by Thomas Eakins called The Gross Clinic, and it's basically showing pre-anesthetic surgery, antiseptic surgery, and the mother of the patient is shown here, just cringing as the procedure goes on. Surgeons at the time wore frock coats as a sign of their status, and they would actually, instead of scrubs, they had these frock coats, and the dirtier, the more blood-caked, the more pus-ridden this frock coat was, the more of an amazing surgeon you were considered to be. So no concept of germ theory. They had pus and blood just caked into these things. They were never washed. If they dropped a knife during the procedure, it wasn't unheard of to just pick it up, drop it on the sole of their foot, and kind of go back in. Dr. Gross thought that this idea of nanomolecules was ridiculous. He thought that surgery needed to be fast because the damage to wounds was caused by oxygen that entered the body and caused damage, and that's why you had to be fast. Oxidation had been discovered, and he held very firm that surgery had to be fast for that reason. So a lot of frantic activity, dark overcoats, and so forth. About 20 years later, the same painter did this painting for a surgeon and professor who was retiring. His students actually commissioned it, and this is demonstrating the changes that occurred in that short period of time when antiseptic surgery came in. We have white coats. Why are white coats a really good thing to have if you're concerned about infection? Yeah, you don't want to see, you want to see the blood, you want to see the pus, you want to see the stuff that's going to be an infectious source of material and get it out. You don't wear it again, you cover it, you take care that it's not there. So Lister prevailed, and Lister prevailed for three main reasons. He had better outcomes, and even though he wasn't well respected in England and the UK, in Europe, when he did presentations, people listened. Surgeons from all over the world started trying to use Listerian techniques to make surgery more effective, and eventually you could not deny that it worked better and people survived. Lister was a very humble and persistent man. He didn't get offended too visibly when people would doubt him. He just kept trying to sway them with relentless kind of focus on his results. and he was not someone who let himself get angry to the point where he would bail on it or dismiss someone. And third, he was younger than a lot of his opponents, and he outlived them. A lot of progress happens because the old guard dies off, and that not to be the way it is, but when people have achieved a certain rank, they tend to be a little more set in the things that got them there, and that can make innovation a little bit challenging. So eventually, antisepsis gave way to aseptic technique. Just don't let germs in there in the first place. Sterilize things, have a sterile field, have a sterile room, and antisepsis fell by the wayside, not because it was ineffective, but because better results were figured out and worked on. And so here's that name of that other painting, the Agnew Clinic, basically showing how that is. And you can see that the surgeons look more relaxed, and the onlookers are not quite as horrified as they were prior. Let's see, do I have one more? Let me back up real quick. One last thing is, towards the end of their lives, Louis Pasteur and Lister actually met at a conference, and they embraced each other. And Louis Pasteur, who was well known to have a really big ego, said publicly that if the only thing his work ever did was make Listerian surgery possible, then it would have been worth it. So they, greatly admired each other and greatly admired what they'd each done to make germ theory and its, the fighting of germs possible. All right, so now we're going back to America. America, medically, surgically, was a backwater. We'd gotten off to a pretty good start in the post-revolutionary era, but the Civil War just derailed medical training and pretty much everything in the country, for a long time. For 20 years, we'd lost so many people, lost so much money, there was so much rebuilding to do, and American medicine really was considered to be pretty terrible. William Halsted changed that in his lifetime to make American surgery the highest status, the most effective version that was then spread throughout the world. Now, he started by training in Europe. His family was independently wealthy, so instead of going to proprietary school, he actually went to medical school in Europe, toured various hospitals, learned his techniques there, and was exposed to Listerian technique. And he came back to New York and wanted to set up a Listerian surgical theater and was told he couldn't, so he and some friends got some money together and actually put a tent on the hospital grounds that became their Listerian surgical field, and they were actually able to do antiseptic surgery there. He was incredibly active in research. He was looking at ways to make surgery more effective, new procedures, new things to dull the pain, and in his research, he and his friends really started experimenting with a lot of different substances, and they came up with a lot of really amazing things. And he was rocketing to the top of the social and medical world in America. But that just stopped short, and he came crashing down. And the reason was he had started investigating a particular topical anesthetic called cocaine and realized that cocaine could numb peripheral nerves. And you could do surgeries not by knocking someone out completely, but by doing local anesthesia, doing it in the immediate area without the person feeling pain. And he and his friends noticed something. When they were doing their cocaine experiments, they felt really good. They were really energized. They could go out and party afterwards. They never got tired. They thought it was great. Now, he'd been introduced to this because cocaine had been known as a topical anesthetic. Sigmund Freud told Karl Kohler, who was an ophthalmologist. Karl Kohler got the word out that it could anesthetize mucous membranes, and then Halsted and his colleagues started using it as a topical anesthetic. And cocaine was just widely available at the time. Teeth hurt? Here's some cocaine. Kids crying? Give them some cocaine. If that doesn't work, we've got some morphine for them too. So it was widely available, and use of it led to abuse of it. And he and his friends who were investigating it really all dropped low, low, low. They couldn't function anymore. They lost their jobs, lost their positions. Some of them died. And he had put together a treatise on cocaine that took him forever to write. And he was heavily, heavily in the grips of cocaine in the process. So I'm going to read this verbatim just because it's worth it. So neither indifferent as to which of how many possibilities may best explain, nor yet at a loss to comprehend why surgeons have, and that so many, quite without discredit, could have exhibited scarcely any interest in what, as a local anesthetic, had been supposed, this is all one sentence, if not declared by most so very sure to prove, especially to them, attractive, still I do not think that this circumstance, or some sense of obligation to rescue fragmentary reputation for surgeons, rather than belief that an opportunity existed for assisting others to an appreciable extent, included me several months ago to write on the subject in hand the greater part of something comprehensible paper, which poor health disinclined me to complete. So yeah, that's someone who's completely strung out on the drug. It's basically destroyed him. He didn't know any better, but his life came crashing down, and that could have been the end of it. But fortunately, he got some treatment. He relapsed several times, but he was able to get some treatment. His family was wealthy. He could go to some asylums and kind of recover there. And essentially, he was hired by a guy named William Welch, who we talked about in the pathology talk, who was chairing the department at Johns Hopkins, which was the brand new medical school. And he came there as Welch's surgical research assistant. So he worked in the lab, recovered his health, and became a very meticulous surgeon. He really changed his approach completely to become very slow, very meticulous, ligating every little vessel along the way. And it's said that you could be deathly afraid of blood and still watch one of his surgeries because he was so good at hemostasis and keeping bleeding from happening. So he started doing a great deal of anatomical research on surgical problems, and when the person that they'd contracted with to be the head of surgery at Hopkins backed out, he was given the chair of surgery at the brand new school. And he started investigating everything he could. He advanced thyroid surgery, which had never been done before because cutting into the thyroid caused a hormonal storm, or an endocrine storm, pardon me, that would then kind of result in death. Bile duct surgery, he actually did a bile duct removal on his own mother on their kitchen table because he could tell she was having a gallbladder attack that was going to kill her. So he actually did the procedure on her with his sister serving as the orderly and holding mom down because they didn't have any anesthesia there at the time. He worked on aneurysms and conducted one of the first gallbladder removals, as I said, on the kitchen table with his mother. And these are all his illustrations. He drew these. He was a very good artist. And you can see the level of detail that's involved as he looks through the layers of the abdominal wall to create a surgical repair of a hernia, showing you where the thyroid gland is, the vessels that are in the way. And what he's most infamous for these days is called the Halsted radical mastectomy. Now, the Halsted radical mastectomy is what, by our standards today, a relatively brutal technique. It basically involves removing the breast, the pectoralis major, the pectoralis minor, and as much of the lymphatics in the axilla as possible. Here's the thing. It actually worked. Now, up until this point, breast cancer was a death sentence. It was not something anyone was going to recover from, and if you can see this illustration here, the standard of treatment at the time was take 2 spikes, put them through the woman's breast. You can see she's smoking some opium in the upper left column, and good for her. Anything that will dull this pain is going to be worth it. And then ropes are attached to them, traction's put on them, a knife cuts the breast off, and then we cauterize. Her calm face in all of those pictures is got to be an absolute lie. Now, think about lymphatics. Think about cancer. Is this going to help? If that tumor has spread anywhere, no, it's not going to help. It's going to brutalize the person, and then they're going to die of breast cancer anyway because it's spread. Halsted's technique worked because he knew about lymphatics, he knew about the structures involved, and people survived. It went from being a death sentence that left you, kind of unable to talk to your friends and family because of the sores and the smell, to being something that could be survived. And we have way better options nowadays because early detection is far more advanced. So the radical mastectomy is a brutal technique, but it's one that works. And the reason we don't do it as much anymore is because we have better options because of early screening and being able to stage cancers better. And here actually is one of his illustrations of the process. You can actually see the fascial planes, you can see the lymphatics and so forth that's working on there. So it still was a massive step forward. And so just because something is brutal by our standards, put it in the context and remember at the time it might have been a big step forward, but we always try to improve as our technique gets better. Now, Halsted is also credited with adapting our current residency system to surgery. a colleague of his, William Osler, who is worth talking about, but I don't have time, was a chief of medicine at Hopkins and came up with the residency system, and Halstead adopted it very heavily because he really liked the progressive responsibility method. You train the senior resident trains the other residents, and other residents train the junior residents. There's a chain of hierarchy, and if someone's not there, someone else can step in and do the procedure. So senior students monitoring and supervising junior students is standard practice now, but this was something that Halstead and Osler really put into place. And if you guys like the latex gloves you get to use in the anatomy lab and in surgery, congratulations, thank you, William Halstead. He came up with the idea and talked to the people at the Goodyear company to make rubber gloves that could be used in surgery. And he actually did this because his nurse, who was, he was very fond of his nurse, she was really good, her hands would react to the carbolic acid by getting really inflamed and red, so he decided, I should do something to help her with that. So he came up with rubber gloves. They later got married, had a very strange marriage, but by all accounts a successful one. But yeah, that's why we have rubber gloves. Here's the thing. The residency system worked really well for him because he was very erratic. He was brilliant, came up with a lot of good ideas, but sometimes he would just disappear. And his colleagues would have to be like, oh crap, okay, well, who's senior resident? You're doing the procedure. And they would, he would disappear in the middle of surgery sometimes. And sadly, the reason they found out is that he had indeed kicked his cocaine habit, but he'd done so by taking opium and morphine. So he moved from one drug to another that allowed him a little more control of his addiction. So just the fact that he was able to function at all, let alone do the amazing things he did while in this state, is amazing. And I think if he would have been able to get actual recovery, there would be no end to the things he could have done. Now, he trained a lot of surgeons, and one of them was the first neurosurgeon, a guy named Harvey Cushing. Now, when you think about Cushing and Cushing's disease, does anybody have a quick, word play with Cushing's disease? What's Cushing's disease all about? Anybody? It's an endocrine disorder. So why would a neurosurgeon be having an endocrine disorder named after him? It's because it originates in the pituitary gland, and he was able to deal with it by doing procedures there. So Harvey Cushing is another well-accomplished artist. He did that drawing on the right. Looks a lot like William Osler, someone he actually really had a lot of admiration for. But he trained under Halstead, but really didn't like him. He didn't like his demeanor. Halstead was very gruff, very what we'd call abusive by today's standards, and essentially he would look for ways to outdo his teacher. And so he started investigating cocaine as a topical anesthetic, but not getting addicted to it. And he was very proud that he was able to get cocaine and local anesthesia to a degree that his teacher never was because of his history with it. So he treated trigeminal neuralgia. It was the first procedure he came up with that really dealt with a nervous system problem. And trigeminal neuralgia, for anyone who doesn't know, it basically causes any contact to your face, even a breeze, to cause horrible stinging pain. And it really hurts. And until there was a treatment for it, the most common outcome of trigeminal neuralgia was suicide, because it hurt so bad you couldn't sleep for days. Anything would set it off. And when you can't sleep, you make bad decisions. And so suicide was very commonly followed this procedure. So what he did was he found a way to go cut the trigeminal nerve. Now, that's not a small thing. Basically, you're going to lose sensation on your face, but it's not going to hurt anymore. And that was a big step forward in treatment of this. And he started looking at other ways to treat nervous disorders, things involving the pituitary, hematomas, aneurysms, and so forth. And over the course of his career, he did 2,000 operations. And the mortality for operations involving the central nervous system went from about 90% to around 3%. Not all because of him, but largely because of him. He had another student of Halstead's that he was in kind of competition with, a guy named Walter Dandy. And Cushing didn't seem to really take the competition too seriously, but Walter Dandy was all about competing with Harvey Cushing. He was a little bit driven to outdo Cushing. And he is the one who figured out how CSF circulates, how hydrocephalus occurs, and how you can actually treat it with, a stent. And he's also the person who kind of first described how a herniated nucleus pulposus can put pressure on the spinal nerves and cause sciatica and other nerve pain. He came up with a procedure called pneumoventriculography, and thank God we don't use this anymore, but let me tell you what it is. Back then, they had come up with x-rays. X-rays were a real thing, but they didn't have any other imaging modalities. So if you had to take an x-ray of someone's head to see what was going on in their brain, you'd be out of luck, because it doesn't really look like much in there beside the skull. But he knew that air was much more radiolucent. So he would open a patient's skull, drain the CSF from their ventricles, take an x-ray, and then he would be able to see some of the masses that might be pushing into the ventricles and things like that. Still a horrendous procedure. I would not go for it. But it was a way to actually get around the problem of imaging the brain. Because back then, brain surgery didn't have imaging to guide it. So imagine you have to go remove a tumor or a hematoma, and the only thing you have to tell you where it's happening in the brain is a very thorough neurologic exam ahead of time. And if you open up the skull and that tumor is not where you thought it was, that's not so good. So neurologic exam was the only thing they really had to locate where they needed to make the incision. So the two of these people in their competition basically invented modern neurosurgery, and imaging modalities got better and better, and thankfully now we have things like MRI and CT that let us look before we have to cut and verify. Now, that's led to a decrease in people's skill with the neurologic exam. Obviously, it's still good to have that, but it's better that we suffer from too many options rather than having to rely on one exclusively. Now, Hopkins still features prominently in the next major step forward surgically, which is going to be repair of the heart and the great vessels. For a long time, the phrase nolo tangere was associated with the heart. You will not touch. It was felt that anything involving the thorax would be immediately fatal. The mediastinum and heart could not be dealt with. You just had to accept that any problem there was going to kill someone. The first person to really cast doubt on that in this chain of events her name was Helen Taussig, and she was a graduate of Hopkins, and she was a cardiology fellow there. Now, Hopkins was kind of touted as being an equal opportunity school where women could be, on the same basis as men, but not surprisingly, the options were not quite as egalitarian as they sound. And after her graduation, she was unable to find other options, and so she was basically given charge of the pediatric cardiology unit at Hopkins. Now, you can't do anything about the heart. So basically, her job was to make her pediatric cardiology patients as comfortable as she could until they passed away due to the progression of their disease. But that wasn't good enough for her. She started investigating with fluoroscopes how the blood circulated through the hearts of the children who had different malformations, what kind of murmurs they had, what kind of murmurs they didn't have. She worked with a woman named Maud Abbott at McGill, who had a collection of pediatric heart malformations, and she really tried to understand how the clinical signs could be interpreted to tell you what kind of malformation was there and where the problem was with the plumbing. Now, this is a picture of her taken later in life, but this picture is a lie. And the reason it's a lie is she's wearing a stethoscope. She was actually mostly deaf. So not only was she mostly deaf, she had to do something very osteopathic for an MD. She had to palpate her patient's chest to figure out where the murmurs and the thrills and things like that were, and palpate the beat of the different ventricles and heart and so forth. So if you guys can get your fingers attuned to figuring out murmurs, good on you. It is possible. So instead of dealing with, and then learn with your fingers was one of her statements, could be a very DO kind of centric thing to say. She wrote the textbook on congenital malformations of the heart and created the field of pediatric cardiology. But the way she did it was because she noted that some of her patients with tetralogy of Fallot were doing okay when they had a patent ductus arteriosus, a connection between the aorta and the pulmonary trunk. But if that closed, these patients with a hole in the central area of their heart would get much worse and probably die quickly. So she thought, well, if the ones who have a patent ductus are okay, why can't we create a ductus in patients without it? So she talked to the head of surgery at Hopkins, a guy named Alfred Blalock. He's on the left. And Alfred Blalock was chief of surgery there. He'd worked at Vanderbilt before, and he'd worked on, let me back up, sorry. He'd worked on post-surgical shock, and he and his laboratory assistant came up with a way to increase the blood flow to the lungs by creating essentially an artificial ductus connecting the artery to the pulmonary, the aorta to the pulmonary artery. Now, his lab assistant was named Vivian Thomas, and Vivian Thomas, being a young black man from the Vanderbilt area, wanted to go to medical school, but his savings were wiped out in a bank failure. There were very few universities for black students to go through, and so he took a job with Blaylock, basically cleaning the lab and doing menial work. But Blaylock realized that not only was Vivian Thomas incredibly smart, he was really, really skilled with his hands. And he was able to do surgical procedures, stage them, trial them before they would be used in people. So using animals, they would do trial surgeries that would then be done and adapted to people. And that's what happened at Johns Hopkins. Now, Vanderbilt was actually relatively progressive at the time, and so when Blaylock talked Vivian Thomas into moving to the Johns Hopkins area in Baltimore, it was actually a big deal because Baltimore was known as a fairly racist area at that time, and there was a lot of segregation and a lot of concerns for someone moving to that area deliberately. So, imagine that racial disparity in status juxtaposed with what happened next. They came up with a procedure to treat these tetralogy patients by creating an artificial ductus arteriosus. But they'd only accomplished it in dogs. And in fact, Vivian Thomas had done it many times. Alfred Blaylock had only done it once, and it had actually failed. And so they got a call that a little girl named Eileen Saxon was getting much worse, and they had to go to surgery with her if they could, as quickly as they could, or she was just going to die. So they brought her to surgery. Alfred Blaylock scrubbed in, and as he's getting ready to cut, he stops and just shouts, "I need Vivian in here right now." And so Vivian Thomas came in, stood on a stool behind the chair of surgery at Johns Hopkins, and basically talked him through the operation the whole time. Like, no, don't pinch that yet. Okay, put that suture that way. Okay, good. And so essentially walked him through it. And according to people who were in the room, they didn't know it was successful until they actually removed a clamp and they saw this little girl who had been blue as some scrubs her whole life turn bright pink as blood actually was starting to get from her lungs into her system. So this treatment was actually a great step forward. It was the first successful major surgery on a cardiac area. And there's an HBO movie called Something the Lord Made. It's about that. It has Alan Rickman. If you want to hear Alan Rickman speak with a southern accent, this is your movie. And I'll warn you right now, you will have tears streaming down your face at the end. I did. I'll own up to it. So they developed the Blaylock-Taussig shunt, and essentially, not surprising for the time, Vivian Thomas was basically ignored thereafter for the glory. Now, he maintained his job. Alfred Blaylock tried to support him, but Blaylock didn't go out of his way to make sure that he got equal credit for it. And it wasn't until 1976 that Vivian Thomas actually received an honorary doctorate from Johns Hopkins after he'd spent 30 plus years training all of those surgeons who had come through there and basically created the field of cardiology and surgical cardiology and so forth. Now, eventually, the Blaylock-Taussig shunt was dropped because we came up with the heart-lung bypass machine that actually allowed the heart to be operated on directly. So instead of reworking the plumbing, you could take the heart, stop it briefly, repair the actual damaged structure, and then reattach it. So this actually allowed the direct repair of the heart for the first time, but was only possible because people were willing to actually try to do procedures on the heart. Now, we've moved on from open heart surgery to another field of surgery that had been something people had dreamed about for years but could never get to work, and that is transplantation. In the 1950s, a kidney between identical twins had been transplanted, and people were pretty impressed by that. But the main problem that everyone knew about was the rejection phenomenon. You could transplant things, but it would eventually cause rejection. And the early field of blood transfusion is what led people to understand that. Early on, before people knew about blood types, they would transfuse anyone with anything. And the first one might go okay, but once the person had been sensitized to other antigens on the blood, a second transfusion with that same antigen would actually cause death. And that was understood to be the basis for organ rejection. So at Stanford University, two guys, Richard Lowell and Norman Shumway, were working on ways to do heart transplants. They were trying to figure out the procedure so that when the rejection phenomena could be mastered, they could actually follow through with it. So imagine their surprise when in South Africa, one of their students did a successful heart transplant completely without any kind of warning. So a guy named Dr. Christian Barnard in South Africa did a successful heart transplant, and the transplant worked. The patient survived for several weeks, and instead of being upset, he was actually very happy to have that time. But the initial rush of enthusiasm was kind of tamped down as people understood that the heart transplant would work, but the rejection phenomenon couldn't be countered and eventually would cause these people to die, and people stopped doing them. But later, the original researchers at Stanford came up with a way to actually stop the rejection phenomenon. They were able to come up with cyclosporine-based immunosuppression and tamping down the immune system of the people who received the heart to actually allow it to continue working. And once that happened, heart transplantation again took off, and we're where we are now. It's not a problem of doing the procedure, it's a problem of getting enough donor hearts for all the people who actually need them. So we've reached the point where the technical limitation isn't the problem, it's actually getting enough material to do the transplant. So that's where we are now, and all sorts of different transplantations have been worked through, including heart-lung transplants, liver transplants, and so forth. So what's going on now? Obviously, the progress of science and medicine is proceeding faster than ever, and there are so many people on the planet doing so much good work. In 50 years, it's going to be unrecognizable and hopefully amazing, assuming we don't have some sort of a catastrophic thing in the meantime. So vote for good people, please. So what's going on recently? In 2006, a team at Wake Forest, led by Anthony Alala, were actually able to come up with tissue engineering and create a lab-grown bladder from the cells of a patient who had spina bifida and had a bladder that didn't work. So they were actually able to use his own cells to create a bladder, layer it onto a scaffolding that allowed the cells to grow, and were then able to suture it in and take care of the contracted bladder that was, kind of tightened up and wouldn't expand that the patient had otherwise. So they were painted onto a scaffolding of collagen, and we've even brought 3D printing into the process now to 3D print those scaffoldings and potentially eventually 3D print entire organs as we have different feed tubes for different cell types. Another procedure in 2011 was a lab-grown trachea, and there it is. So we can actually create organs from scratch right now, and the intersection of medicine and engineering is only going to get more sophisticated, and anytime you get a chance to take part in projects that might take a big step forward, jump at it, because the opportunities are only going to get better. And that's it for today. Next time will be our last talk, where we take a look back at not just the good stuff, but the stuff that could have gone much better, and the groups that were excluded from medical training and how they were eventually able to get access to medical practice and medical activity. Thank you guys very much, and we're under 2 hours. Amazing.